So, Dr. Phillips, in the previous video, we talked about the use of SSRIs in high doses, ensuring adherence, making sure there is a long enough trial, like a 12-week trial, and so on. But what about like patients who are either not able to tolerate or don't respond? So one of our readers asked about, patients who are unable to tolerate SSRIs because of side effects. Um, and similarly, another reader talked about her patient who has tried multiple SSRIs with both little benefit and poor tolerability, like sustained nausea, increased migraine, affective blunting, etc. So, if SSRIs are not tolerated or do not work, what would be the next thing to do?
First, I'll start by saying I do everything I possibly can do to help patients tolerate these medications. And I think there's so many things you can do. You can start at a minuscule dose, right? I have a patient recently who was so anxious about the medication and said he had all kinds of side effects. We started with 1 milligram of escitalopram a day. It was very slow titration. We both had to be quite patient.
Yeah.
Eventually got him up to 50 milligrams a day. All his
Wow.
are gone.
From 1 milligram to 50 milligrams, right? That's a
Full
lot of patients.
remission.
Yeah. Yeah.
Oh, yes, full remission. And another patient I can think of, I started 2.5 of escitalopram, eventually
Yeah.
got him up to 40. So I think starting very low with minuscule doses and also trying to figure out, are these really side effects? I think, sometimes people read online, about potential side effects, which the information may not be accurate. And then sometimes they just get very anxious. And so I think just being thoughtful about, is this really a side effect or not? Sometimes that's hard to determine, but did it onset after you started the medication?
Yeah.
What is the prevalence of this particular side effect? If you look at the official product labeling information, if it's only 2%, well, maybe you can never say it's not a side effect, but maybe not. So I have these kinds of discussions with my patients, try to reassure them and tell them that side effects often get better with time. The body does adjust often.
Yeah.
But having said this, there are some patients who, may not respond even to your good doses of the SSRIs and may not be able to tolerate them.
Yeah.
But again, they get tired, you move the medicine to bedtime, nausea, you take it with food. There are all kinds of things you can try. But if they cannot tolerate a specific SRI, then the only really well supported augmentation strategy is neuroleptics.
Yeah.
And the best data are for risperidone and aripiprazole.
Right.
There's some suggestion that maybe risperidone is better if the patient also has comorbid tics, which are pretty common in people with OCD. I prefer, this is just a personal preference, I tend to prefer aripiprazole. I think it tends to be a little better tolerated, perhaps a lower risk of TD, better for mood. But I think those are our two best supported strategies. There's also some evidence to support olanzapine, haloperidol, and quetiapine. We tend to use lower doses. You might use 0.5 to 2 milligrams of risperidone, for example. I tend to stay at the lower end of the dosing range, opposite the SSRIs, right, where we tend to go very high. So, I think augmentation is a good strategy. I'm more, of course, you have to individualize that decision. I'm more likely to augment if I have a partial response with an with an SRI.
Yeah.
You want to hold on to that response rather than switching to another SRI.
That's a great point. That's a great, simple, common sense principle, which is often neglected, which is that if you have partial response, instead of switching to clomipramine, you might go for augmentation first, versus if you have no response, you might switch to clomipramine, for example. Is that what you mean?
Or if you've been on multiple SRI trials with no response, then you might want to try augmentation, right?
Yeah.
We generally do try at least a few SSRIs before clomipramine.
Yeah.
Clomipramine is probably not more efficacious than the SSRIs. Although head-to-head comparisons with the SSRI suggest it's not more efficacious, although some results from meta-analyses suggest maybe it is more efficacious than the SSRIs, but those are different patient population, probably lower response rate, lower placebo response rate in those early clomipramine trials, so you get a bigger effect size. But head-to-head comparisons suggest clomipramine is not more effective. It tends to have, but again, some experts lean towards maybe it is perhaps slightly more effective. So.
But the difference is not so huge that we should go to clomipramine right away or early on. You're saying try at least 2, maybe even 3 SSRIs.
Yes.
And so just to back up, so if we gave the patient a really good trial of one SSRI and the patient didn't show any substantial response, trying a second, just like in major depressive disorder, trying a second SSRI might work, right? Like there's some significant chance.
Absolutely might work. Augmentation with a neuroleptic may work. And of course, don't forget exposure and response prevention, right?
To add that in.
Yes.
But would you, in your practice, would you so after the non-response to the first SSRI, are you likely to try a second SSRI, or are you likely to go to augmentation with an antipsychotic?
I really individualize that decision. I think there's no clear answer from the research base. I think, if I have that partial response to the SRI, I'm more likely to add in a neuroleptic. If the patient has severe depression, I'm more likely to add in a neuroleptic, especially aripiprazole, I think can be very helpful.
Yeah.
Comorbid depression. Are there any reasons in this particular patient not to use a neuroleptic? In that case, you have got to look at their medication history. Of course, if they've had lots of augmentation trials with neuroleptics, you're going to be more likely then to switch to another SSRI first. Or a bit later down the road, clomipramine. So I think you've got to look carefully at the medication history and what have they had before, how adequate were those trials. So I think it's hard to come up with a definitive answer that works for every patient. Use your judgment, I think.
Yeah. So but a reasonable option is to try a second SSRI is a reasonable option.
Yes.
Augmenting with an antipsychotic is a reasonable option. And then if these options are either failed or for some reason not appropriate, then switching to clomipramine.
Yes.
And you are not recommending clomipramine early in this algorithm. You're recommending, because of tolerability issues, to keep clomipramine a little bit lower down. Yes. Am I understanding this correctly?
Yes, because of course, not everyone gets side effects with clomipramine, but they can. I recently used it with a patient who got urinary retention on a low dose.
Yeah.
It's an excellent medication, but it does tend to have more side effects. And I like you should be monitoring levels of clomipramine and its metabolite, and I monitor EKGs also, and I would recommend that just to err on the side of safety and being somewhat conservative and careful.
Yeah.
And so that gets a little bit more complicated. Your patient has to be willing to get the labs done and get the EKGs done, and so it's just a little bit more complex to prescribe.
Right.
Also,
okay.
These SSRIs are very straightforward and easier in that sense.
Yeah. So that's again a good segue into asking if you could please just I think that our listeners are likely to be much more familiar with using SSRIs as compared to using clomipramine, and may, especially our younger colleagues, may benefit from some little bit more guidance from you about how exactly would you prescribe clomipramine. So if you had a patient whom you felt like has tried 1 or 2 SSRIs or maybe tried augmentation, whatever, and you feel like they have moved through 1 or 2 steps and switching to clomipramine seems to be a better idea. My first question would be, would you switch to clomipramine ahead of adding clomipramine?
That's a very good question. You can add clomipramine to an SSRI. You have to keep in mind that the SSRI can dramatically, in some cases, increase the level of clomipramine.
Yeah.
And because
if it's a 2d6 through the cytochrome, if it is a cytochrome P450 2d6 inhibitor, like paroxetine or fluoxetine are potent inhibitors of 2d6.
Yeah. And, and clomipramine being a tricyclic antidepressant has a low therapeutic index and risk of seizures and cardiac effects, et cetera. So I start at 25 milligrams a day. I should answer your question. I think you could go either way. It's simpler to just have the patient on the clomipramine without the SSRI.
I would agree,
Yeah. On the other hand, and there, you worry a little bit about risk of serotonin syndrome when you start combining clomipramine with an SSRI, although I've never seen that happen with that combination. I've done it a lot. I used to do it more before we had the atypicals, right? So I don't do it as often anymore. But I think, again, if a patient's had a partial response to an SSRI and it's a good enough partial response that you want to hold on to that, then I not risk losing it by switching off the SSRI. I'm more likely to add on the clomipramine. But I'm careful. I stay in the much lower dosing range.
If you're combining, you would use lower dose than if you were using clomipramine monotherapy.
Yes. And I start getting blood levels at very low doses. Especially if you have a slow metabolizer, you want to get an EKG and a blood level on by the time they're on 50 milligrams a day. So it's simpler to just switch over to clomipramine, but I think you can either add on to the SSRI, but you have to be very careful when you do that, or just switch over to the clomipramine.
So if we are using a combination which is probably might not be ahead of switching, then at 50, start with 25 milligram, and then go up to 50, and then get a serum level as well as an EKG before proceeding further.
I do. And sometimes I think it's also nice to have a baseline EKG in these patients. And so when possible, I get that done. I should also mention, though, that this combination of clomipramine plus an SSRI is not as well studied as the neuroleptic augmentation strategy, so listeners are aware of that. But clinicians who treat a lot of OCD or body dysmorphic disorder will sometimes use this combination.
Right. Okay. And so, getting EKGs is such a pain in the what.
Yes.
So that itself is a little bit of can be a barrier to using clomipramine in certain, depending on where one is practicing, but it's essential. So, and then what about if we are switching to clomipramine? So we get the patient to move to clomipramine. You would start again with 25 milligram and titrate up.
I start 25 for at least a couple days a week. Make sure they're tolerating it okay. Go to 50, and then assuming that they're tolerating it well and you're not seeing any side effects, I might increase by 50 every couple weeks. And get up to, if you need to go up to 250, go up to 250. Again, that I don't go above that FDA limit with clomipramine, unlike most of the SSRIs. And just keep it at 250. Of course, if the patient starts getting better on a lower dose, you don't have to keep going up. You can wait and see, give it more time, because keeping in mind that 12-week trial for OCD. Or if they have trouble tolerating it, you might slow down that titration schedule to just make sure they're able to tolerate it, and hopefully side effects will get better with time, and then you can raise the dose further if needed. And then you want that full 12-week trial, and at least a month
same as for SSRIs with clomipramine. Also, we are looking for a 12-week trial.
At least a month on 250 or whatever the maximum dose is that they can tolerate. And after 3 months, you decide, is this worth staying on or not? Is it helpful or not?
So with monotherapy, what are the times when you would get a level and an EKG at baseline, and then just so that people have a rough guide, and then they can individualize from that guide?
I might get one at 50. And I think some experts would say that's too soon. But I have seen occasional slow metabolizers who had very high blood levels and EKG changes on 50 a day. And once you've seen that a number of times, I don't know if you've seen it, it's not common, but I've tended to get a little conservative with that. So I might check at 50, and I might check, at 150, and then I might check at 250, something like that. I think some experts would say only check at the higher, you only need to check at the higher doses. But again, I'm a little bit more conservative that way.
Better to err on the side of caution. And then also, depending on, other risk factors, if the patient is older or they have a cardiac history, etc., you would be way more conservative. But I just wanted the listeners to have some idea that it's not just one time that you check the level.
Yes, right.
And EKG, you might do it at least 2 or 3 times, depending on how much you titrate the medication. And then once the patient is...
I'm glad you mentioned the cardiac history because, occasionally I'll consult with a cardiologist, is it okay for this patient to even be taking a tricyclic antidepressant? So keep that in mind.
And then if the patient does do, God willing, does well on the clomipramine, let's say 200 or whatever, and you keep the patient on clomipramine, would you when would you check level and EKG after that? Assuming is there any need, or only on an as needed basis if they have some kind of problem?
On an as needed basis, if another medication is added in that might affect the blood level, or the patient inexplicably starts developing some side effects, or I suppose if you wanted to be very cautious, you might do it annually or something like that. I don't know that there's any one, perfect timeline, frequency for everyone.
Right. No, so this is great because I really appreciate your sharing the usual structure or commonly how you might do it, because younger people who have been trained in more recent years are losing the ability to prescribe tricyclic antidepressants. And I don't understand how you can be a quote unquote specialist or a psychopharmacologist or or at least a specialist in mental health treatment without being able to prescribe a range of medications. Because
one thing about yes, I agree. Sorry, I don't mean to interrupt, but one thing about the clomipramine is the toxicity and overdose, right? Like all of the tricyclics. So I have kind of detailed conversations with patients about where are they going to keep the medicine. The medicine cabinet is not okay. And I always ask, do you have small children in the house? Do you have pets? How often do you have visitors who might go into your medicine cabinet, which some of my patients have done, so they go into people's medicine cabinets and they take the meds that are in there. So,
wow.
So, I actually, especially if they live with other people, I recommend they buy a safe and it seems very extreme, but if there's small kids in the house, if there are other people who might be depressed, I don't want anyone overdosing on this medication. So I want to make really certain that, and of course, we talk about this for all the medications, but of course, the clomipramine is the biggest worry in terms of toxicity and overdose.
Right. Okay, that's another great practical point to follow.